Hello students, I am Dr. KOMAL, Assistant Professor from VIDHYA, Faculty of Ayurvedic Science in Jyoti Vidyapeeth, Women's University, Jaipur, Rajasthan. Today's topic is anal fissure. First of all, introduction. Anal fissure is the linear or oval-shaped ulcer in the squamous epithelium of anal canal distal to the dentate line. Occurs equally in the both sexes. Tends to occur in younger age group. So, etiology, multifactorial and initiating factor. Posterior perineal posterior perineal descent coupled with the excessive stretch of the endoderm, vulnerable to tearing. Relatively fixed anocoxial ligament posterior, extreme ball pattern, hard stool and explosive diarrhea, excessive straining and defecations. And the third is perpetuating factor. Perpetuating factors, intrinsic and sphincters hypertonia, reduce production of nitric oxide. Relative tissue ischemia, paucity of branches of inferior rectal arteries, less dense capillaries in both subanodermal space and within the ias of the posterior middle line, the posterior perineal descent. And the classification is historical according to duration of symptoms. First is acute and chronic. So acute is symptoms less than 6 weeks and chronic is more than 6 weeks. The symptoms occur. Less than 6 weeks, but examination show features of chronicity. Based on morphology of the fissure. The superficial fissure is severe pain plus minus bleeding. Superficial separation of the endoderm with sharp edges. Base on the fissure does not reach in the internal anal sphincter. Vast majority heals spontaneously within the days or within the weeks of appropriate conservating treatment. And the last is deep fissure. So deep fissure, deep often with the visible fibers on the internal anal sphincter, minimal granulation tissue at the base, white pure shaped ulcer, thread of induration ulcer edges, a distal skin tag, and the proximal hypertonic anal papilla. Latter is not universal. Often persistent and either tend not to heal without intervention and recur regularly. They result chronically from prolongation and repetitions of the causes of superficial anal fissures, or they may arise de novo as the result of deep tearing right from the start. Now locations. Locations is posterior midline. 75% fissures occur. Anterior midline 25%, both anterior and posterior 3%. Atypical locations or multiple. So it is the cause for Crohn's disease, trauma, tuberculosis, syphilis, AIDS, and anal carcinoma. That all is the cause of anal fissure. Now, symptoms is the most common anal pain. Predominant symptoms during defecation and may last for several minutes to the hours or the entire day, like knife cutting, rectal bleeding, minimal and bright red colors, and pruritus NA. A physical examination visualized by gently parting of the buttocks with the version of the anal verge. Position of fissure, feature of acute and chronic fissure, proctoscopy, sigmoidoscopy is of the little value. In the acute setting, when there is a strong suspicious or secondary pathological, these procedure can be done under anesthesia and when surgery is being undertaken. So now diagnosis is characterized description of symptoms, generally easily confirmed by physical examination only. And the concomitant presents when the patients complain with anal pain. We can think perianal abscess, anal fistula, inflammatory bowel disease, sexually transmitted disease, or anal carcinoma. In older, particular female, obstructive defecation. Atypical fissures, painless, non-heavy. Further evaluation via examination, possible biopsy, and cultures. And now we come to the treatment. First, non-operative and operative. Non-operative first-line management both in acute and chronic anal fissure. Half of all patients of acute and chronic anal fissure will heal with non-operative measures. Not as effective as surgery, lateral recurrence is higher, about 50%, with non-operative treatment. Associated pain and bleeding from trauma is sentinel piles, persistent tenesmus, and surely is due to presence of fibrous polyp, and side effect on non-complaints. And operative for treatment failure, sentinel piles, surgical excision of SP and fibrous polyp relieve symptoms and offers good healing for patients. Has been described as the initial mode of treatment, causes lack of behavioral changes. Non-operative management treat both initiating and perpetuating factors concurrently, dietary advice, medication, biofeedback, perianal support, manual or modified toilet seat, sitz bath, and topical preparation. Now, topical preparation is combination of anesthetic, anti-inflammatory, and antibiotic. Variants synchronic HCl, local anesthesia, and hydrocortisone. Atypical anal fissure. Address the primary disease, otherwise the management is seen. Among Crohn's patients, anal pathology leads to symptoms identified in 42% of patients. Commonest in the perianal abscess, 29.5% patient, anal fissure 27.6%, and anal fistula 26%. It's atypical deep, broad-based fissures have occurred. So it's all about anal fissure. Hope you can understand and it is beneficial to you. So, thank you.